In summary, this is a case of a patient with a KRAS mutated metastatic colon cancer who had progressed on first-line FOLFOX plus bevacizumab, then proceeded to second-line FOLFIRI plus bevacizumab, and is now in third line and has options of 2 different oral agents.
Thank you for the case discussion, Mike. So Greg, tell me, we saw this interesting thing about NGS testing. So when do you normally, from your oncologist, when do you normally get the NGS testing for colorectal cancer?
It really depends. We've been doing a lot of foundation medicine, commercial NGS testing for a while. So I think the oncologists in our area are fairly comfortable with that test. So we do a lot. I think typically when the patients either aren't responding, they have a refractory disease, or maybe they don't have MSI high, or something else potentially targetable through your normal frontline type therapies.
So tell me the difference. They've always come with that. What's the difference between IHC, PCR, and NGS testing, the expanded NGS testing?
Yeah. So specifically in colon cancer, usually when they're talking about the immunohistochemistry, they're doing immunohistochemistry specifically for the mismatch repair proteins. So it's just an antibody-based test looking for the protein expression of MLH1, MSH2, MSH6, and PMS2, which are typically the 4 most frequently mismatch repair altered genes. So that's usually when it's any type of protein-based test. And then PCR is just polymerase chain reaction, and so traditionally that had been more looking at just single genes. So potentially what people were doing for ROS testing initially, and then usually what people refer to as next generation sequencing. Some people don't like that; they prefer the term massively parallel sequencing. It's essentially millions or even billions of PCR reactions that are occurring simultaneously on a chip, and it allows you to interrogate many gene regions and potentially even multiple patient samples all in the same reaction.
Okay. Now tell me, there's been a lot of discussion in the GI world also about this liquid biopsy. Is in the ctDNA. So what are your thoughts about testing from the tumor versus ctDNA?
Yeah, it seems like most places. I think MD Anderson, who's kind of been the pioneer more with non-small cell lung cancer. Traditionally, I think people are most comfortable that at least up front you're doing some type of tissue-based test to identify the mutation. But then obviously with non-small cell lung cancer, where there's certain resistant mutations, and it can be a little bit more difficult to maybe get a second biopsy. I think we've seen a lot more of the plasma circulating tumor DNA, looking for those specific mutations. But we've seen certain instances where potentially a tissue biopsy isn't feasible, and in those cases, liquid biopsy has been used as an alternative.
Okay. Richard, I'll come to you. This is a great clinical question. We talked about this before, that a new patient comes in, you have a biopsy. Are you sending it for all NGS at that time, just an NGS panel, or do you test for what we talked about before, BRAF, MSI, and the expanded RAS?
So in my practice, because you have a sort of a lack of tissue, right? The tissue is always an issue. When you see the patient, you have a tissue. And if you send one testing for BRAF, one test for RAS, MMR, you're using all the tissue up. And then at the end, when let's say they progress at the first line, you're out of tissue, then you have to do another biopsy or track the tissue down from outside the hospital. So in our practice, we like to get everything in one thing. So we have an internal panel of 200 actionable mutations. You could send to foundation testing where they have 400, obviously, panels as well. So I like to do everything up front for the reasons that we talked about, the testing for the RAS, the BRAF. It also could test for MSI status as well. And there are other subtle fusions that's out there that doesn't happen commonly in colon cancer, such as TRAC fusion, the RET fusion, the ALK fusion, which is about 1% or less. But nice thing about this, even though it's very, very rare, there are targetable, actionable fusions where there are drugs out there that's in a trial basis where you could even get off-label, and some are approved for TRAC fusion, it is approved, where the response rate can be high, 75%. They are durable. The patients, this could be life-saving for certain patients. Therefore, in my practice, I like to get everything up front. So I have a battle plan until you have a TRAC fusion around. If you have TRAC fusion, that's a therapy you would use in second line, possibly. Or if you have a BRAF mutation, you know what to do. So in my practice, I like to get everything up front, if possible.
But tell me this, rare is rare, right? So let's say the community practice, it showed us like in the community practice when they're doing it, these tests are obviously expensive, versus doing an IHC and, testing for a couple of genes and everything. And so, and what they've shown is, let's say the performance status goes down in these patients and everything, you cannot, use this testing. So there's, what would you recommend? What is your practice? Would you do everything up front? Or would you say, hey, I'm going to test for these 4, let's say, if the tissue question was not there, but let's say I'm going to test for this KRAS, extended RAS, BRAF, MSI at the beginning, because it'll tell me things which have been approved or I can use. And then after my first or second line, at that time, I would go, if the performance status is good, if clinically they look good, that's the time I would come in and do maybe an NGS testing. So I don't just test it blanket in the beginning and then the patients don't get it because, let's say, their disease just is uncontrollable.
Well, the theme today, of course, has been that this is personalized, so not every patient should get complete NGS testing up front. It's not going to be appropriate for a lot of people. However, there are some subtleties, one of which is that physicians should know what's actually being tested. And a good example is with KRAS. Now, I always assumed that when you sent that test off, we were getting exon 2, 3, and 4, and in reality, we weren't. We were getting exon 2 predominantly. And so to get all of the possible mutations, for us, it actually involves getting next generation sequencing. So we find it valuable to do it up front, for that reason perhaps alone. It also does give you a baseline. Most of these mutations are not going to go away, and so they'll presumably be there later on, and it then allows you to use a liquid biopsy, as you pointed out, subsequently. So if somebody is being treated with, for example, anti-EGFR therapy, we have sometimes seen mutations develop that render the therapies no longer effective. And the only way you can realistically follow for that is with a liquid biopsy. And so I think knowing what the mutational status is up front does allow you to plan for later. If you find there is HER2 amplification, you know that's going to be an option. Because the mantra in GI oncology, anyway, has been this continuum of care and being able to sort of anticipate what therapies you're going to have available for the person over time. And I think having all the information available up front allows you to really do the continuum of care in the best possible way.